The next topic here is dorsal root ganglion stimulation. Another quick conversation here, and then I'll go over into the lab and see if the specimen will allow me to demonstrate this in a way that looks smooth. Okay, so objectives here are to review relevant anatomy and mechanisms of action for DRG, discuss patient selection criteria, highlight some of the evidence. The references are all going to be within these documents for you because clearly within 12 or 15 minutes, we won't have an opportunity to get into the depth of that. And then review also some of the safety outcomes. All right, so the evidence, why is DRG ideal for the treatment of focal neuropathic pain? I think that's what you need to remember, focal neuropathic pain in terms of patient selection. What we know is that there is abnormal anatomy in the DRG in instances of peripheral nerve injury. There are excitatory inflammatory changes that occur in and around the surrounding glial cells within the DRG that cause a release of pro-inflammatory neurotransmitters and then increase neuromembrane excitability. So when you look at an injured nerve, peripheral nerve root, what you'll see is that there is as I mentioned, this hyperexcitability is evident in animal studies that have this situation. You see the frequency of the nerve firing in the blue diagram on the right-hand side of the screen. What happens is the dorsal horn continues to fire its impulses even post-resection, a traumatic resection of the nerve. This doesn't happen if the injury occurs proximal to the DRG. The DRGs are a unique structure. They have unique characteristics that make DRG stimulation favorable in some circumstances. What you might remember is that this is a T-junction type of a cell. So you have a cell body, the soma, within the swelling of the dorsal root ganglion. The axon projects, and then there is it's kind of like, I guess, not pedicular, but there it goes. The axons go in both directions. So field stimulation is able to interfere with the nerve impulses in the axon in both directions. So there's a suppressive effect proximally as well as a interference with the peripheral stimulation that extends out to that is extending centrally from the periphery. The AP, the action potentials travel down from the stem to the T-junction, and then there is an increased probability of propagation from the stem to the central process in circumstances of peripheral nerve injury, which is where DRG has its action. So these probably are causing PTSD of your medical school, some of us more recent than others. The dorsal root ganglion lead is a lot tinier. It's a lot smaller than the conventional leads that you are familiar with, most likely. They are designed to stimulate the soma and then to interfere with this transmission, this hyperexcitability effect. There are 4 little contacts on the lead, so there is enough length that one or more of them will be able to stimulate that soma. And as I've mentioned, it blocks conduction of afferent impulses selectively in the nociceptive afferents. The stimulation frequencies are between 50 and 100 hertz. So these are, on the DRG, these are subthreshold frequencies of stimulation for most patients. And within that range, there is no difference. It's a very patient selective assignment. So what you're going to see when you observe a patient being programmed with DRG is that you place the lead over the DRG, over the soma, the swelling of the DRG, and then the programming specialist is going to bring the stimulation up to the threshold of sensation and then back it down. Is it 20%? I think it's back down 20% from the point of stimulation. So, and that in that window is somewhere between the 20 or the 50 and 100 hertz that's listed here. The concept is that this field of stimulation in the lower range of 20 to 50 is ideal for blocking C-type fibers, whereas higher fields of stimulation are going to be more preferential for A fibers, A delta fibers. So you're not going to be getting the vibration that you think of with spinal cord stimulation conventionally in the posterior epidural space with DRG, because the stimulation, the frequency is a frequency that's less likely to be activating the A delta fibers in the soma. So this was, when I was trained for DRG, this was probably like the most, the thing that I took away with the strongest impression. I never understood, never realized how complex the ligamentous structures are within the neural foramen. And I don't think we usually need to know that unless we're doing DRG. I mean, we place, transforaminal needles to do epidural injections, and there's a lot of reasons we explain to ourselves why the contrast diflow may or may not go subpedicular and into the lateral recess, but never quite understood until I saw this picture. It is a really complex area, and when you see me in the lab in a moment, I may be lucky, hope I am, enough that the lead just slides right between those little ligaments, and then there's times that it doesn't. This is the explanation for that. In the lumbar epidural space, the dorsal root is up high in the intervertebral foramen there, or the neural foramen, I should say. Also a consideration. That's why we put this lead right underneath the pedicle, is so that it's expected to be very, very close to the dorsal root ganglion in the cephalad aspect of the neural foramen. So stimulation properties of DRG, the electrical field over the nuclei of the primary efferent neurons that are most in the category of the C fiber. The T-junction acts as a filter otherwise for the hyperexcitability that occurs with a peripheral nerve injury or transection. And DRG is able to interfere with that in that location. There is very minimal CSF around the DRG, so the stimulation amplitudes that are required are very, very low, and we can get very close to this structure. And so for that reason, when you think about neural dose and being responsible users of our batteries so that their lives are long, this is an opportunity to take advantage of those potentials. Post-surgical, so these are some cases. These are some, when you think about the ideal candidate for DRG, you're going to be looking for, as we said, like a specific dermatomal distribution of neuropathic pain, like an ilioinguinal neuralgia, where you know that in all likelihood this is T12 and L1, and you can target that. Similarly for post-surgical causalgia, where you know clearly what nerves were transected and can trace those back to know the greatest dermatomal contribution to those. This can be very, very helpful for patients that have neuropathic pain following a total joint replacement as a last resort in many cases for those patients. And there are other post-surgical conditions that have persistent neuropathic pain afterward. This is also really helpful for a patient that has exclusively foot pain. With conventional spinal cord stimulation, historically, we've considered it a bit of a challenge to really isolate the foot. And with dorsal root ganglion, you can do that by looking specifically at L5 and S1 for the stimulation territory. Dermatomal overview, you can see here. If you are planning a procedure, it isn't hard to plan which levels to approach. I would say that doing L5 is a challenge. That wouldn't be your first level to enter if in your first case. We also do some sacral approaches to dorsal root ganglion stimulation, which are surprisingly not as complicated as you may imagine. So the accurate study is probably the hallmark study for DRG. The reference for this is included. This is a randomized controlled dorsal root ganglion versus conventional SCS study, 150 subjects, and in most of the SCS or neuromodulation studies, the primary endpoint for pain relief is a 50% reduction in VRS, which is similar here. And they followed these patients out to 3 and 12 months. Only 5%, so a very small number of patients, had any A delta stimulation in the ranges of frequency and amplitude that the patients found pain relief. And as you can see, there was improvements in general health, social health. And one of the things that does stand out that, sometimes it can be hard to differentiate all of the SCS and neuromodulation studies because for the most part, many of them look very similar. It's always a primary endpoint of 50% or less reduction in VRS. There's always ODI and some quality of life indicators. But one of the things that stands out with DRG is there has been a little bit more attention to mood disturbance. And so they've pointed out that there is also an associated reduction in emotional complaints associated with chronic pain after this procedure. So there have been a lot of studies performed. This is just a reference that you could pull up at another time, but it's the purpose of this slide is just to indicate that this is a very well studied and restudied procedure over a long length of time. And then the safety data. So this becomes a conversation for sure. There's a perception that maybe conventional neuromodulation is safer than DRG. There's concerns about placing, a lead into a neural foramen, the stress, the trauma of the process of getting it out that neural foramen, and the radicular artery that's right there. This is the data on this. Really, over with a data set of over 500 patients. The safety-related incidence of complications is extremely low and slightly higher, but comparable to conventional SCS. Some of the other things that we talk about are should we be doing intraoperative neuromonitoring with a patient for DRG because of we are really getting intentionally very close to the nerve root, and there hasn't been any consensus on this. So the best practices for dorsal root ganglion stimulation guidelines by ASPN examined this issue. They considered the data. This is an excellent read if you are considering participating in this field. There was a recognition that there could be, in theory, a higher risk of injury to the DRG because of the proximity of the procedure here, but found that there was really not enough evidence for a recommendation. And actually, our patients are our best monitor. So if you are concerned, and the same is true for a conventional posterior epidural neuromodulation cases, if you're concerned about injuring the nervous system, then more important than calling in your neurosurgical support team and doing all the electro diagnostics, perhaps allow your patient to be a little lighter in the operating room so they can communicate with you if they're feeling something unexpected. I mean, all of the medications, save fentanyl and midazolam, in lower doses are going to have an impact on the electric monitoring as well. So I think that it's always a complex decision, but relative to the specific concern, I think you can rely on your judgment. There is not a strong recommendation to have electrophysiologic monitoring. Among the faculty here, do you do electrophysiologic monitoring? Okay. I have not either. But I work with anesthesia to make sure in these cases specifically that I'm able to communicate with my patient. Questions? Silence. So we have a lot of data now about the ability, the efficacy of using conventional neuromodulation. Nevro published recently on, diabetic peripheral neuropathy, and we're seeing this reproduced in other company studies as well. So we can see now that there's strong efficacy for being able to achieve stimulation down to the feet with some programming modalities, but if I would suggest, thinking carefully about your situation. If it's a unilateral distal limb, or if there is a a monodermatomal neuropathic pain syndrome in the thoracic or lumbar spine, this may be the procedure for you.
Okay, why don't we transition over to the lab? We'll knock that out before, and then we'll get together for a picture, then lunchtime. Does anybody have any questions?
How many levels do you think is a threshold before you start thinking about SCS instead for DRG?
So I'm going to ask you to clarify your question a little bit. And it was also asked to repeat the questions. So there's a lot of people watching live, remote. So how many levels do you need to consider before switching to SCS? It's really kind of it's for piecemeal, for foot pain, for groin pain, for a single swath of territory, a left knee. DRG is ideal. It's really hard to get just isolated feet with spinal cord stimulation if it's not something like painful diabetic neuropathy. With PDN, it's very good. I mean, we're able to get 80 for 80. 80% of people get 80% reduction in pain, and this is something we can actually believe. I see this clinically all the time. But to divide it into body parts, so if you were to have an isolated body part, DRG is great. So some of the off-labels, post-herpetic neuralgia, post-thoracotomy pain, the inguinal pain after herniorrhaphy, things like this. This is the territory of the DRG. And you can think of larger swaths of territory, just go ahead and do spinal cord stimulation. And this has been very good of late. And the comment that Dr. Lee made about the spinal cord stimulation for painful diabetic neuropathy is profound. It's not only do you get improvement in the pain and function, but you get reversal of some of the neurological deficits, motor, sensory, reflex, objective improvements if you examine these things objectively using the painfully fastidious neurologic examination that they put you through with a monofilament test, pinprick test, and it's for those of us who've done that. It's we know it has to be accurate because it's really detailed, and also the dysesthesias, the burning, tingling, numbness, cold, those will improve in 2/3 of the patients.
Thank you.
Yes.
For these people with focal problems, are you thinking of peripheral nerve stimulation before stepping to DRG?
So that's a good question. It kind of depends on what it is. So, peripheral nerve stimulation is very good. I tend to use that more for things like shoulder pain, right? If somebody has shoulder pain, a peripheral nerve stimulator would be better than a DRG because, it's very difficult to get all the way up 5-6, for example, in the cervical spine. But if you're doing it for PDN, I would never do bilateral peripherals. I mean, come on, just use the spinal cord stimulation. It has good data associated with it. So it kind of depends. In knee pain, and then that's kind of controversial because you could put, and we'll demonstrate the PNS. Dr. Roper has a good talk on PNS. We'll demonstrate the techniques for the knee, but you can also get knee pain with dorsal root ganglion stimulation. So it varies according to the clinical application, how difficult or easy it is for the patient. Keep in mind, any type of peripheral nerve stimulation you put in, it doesn't operate by magic. There's no implantable IPG for this. You have to stimulate peripherally. So you have to put the power source from the outside. You have to make sure it's convenient for the patient, et cetera. Dr. Lee, we ready to go? Go ahead and take a question while we're preparing.
Do you ever consider doing a peripheral nerve block as just confirmation if it's a single nerve level, for example, like a saphenous nerve block for the knee?
So I always do a peripheral block. Having said that, some of the least accurate blocks are genicular blocks. So there's data on both sides of the fence. We've done Visco trial, for example. In the Visco trial, we had to do nerve blocks on every single person. And we found that it doesn't necessarily correlate with success is the real issue. I find that, you know, doing an anesthetic discography, for example, has a high degree of correlation to site of pain and then what happens after treatment. Suprascapular block for the shoulder, in my opinion, is a lot more accurate than a genicular block for the knee. So it just depends on body part, but as a habit, you know, my rule is measure twice, cut once, or not at all. And if you can do a block to predict success, why wouldn't you? So in most body parts, spine, cervical, thoracic, lumbar, the prediction is very good. Certain joints, shoulders, very good. Certain joints, knee, not so good. But yeah, I do make it a habit of doing blocks for every single thing that we do and measure pre-post pain levels. You should be measuring pre-post pain levels for every epidural you do, for every facet or medial branch block you do, and certainly for all discography. And that's, if you don't do it, you will be soon enough, or you won't get paid. How are we coming along back there? So, show of hands, how many people here are doing DRG stimulation? Okay, so that's about 20%. How many people are doing spinal cord stimulation? That's about everybody. So, yeah, DRG is not done nearly as common as spinal cord stimulation, but it is a very good procedure. And it's technically more difficult. So what Dr. Lee is talking about, whenever you go up, you have to make sure and get the right angle to begin with. You have to make sure that your 7-iron is going to shoot straight right into the frame. And whenever you come up to the frame, and you sometimes will have to put consistent, steady pressure to get through the ligamentous complex that surrounds the DRG. That's a very overly complicated drawing, but accurate representation of the intraforaminal ligaments. So I think we're about ready to kick this off. Dr. Lee, are you ready to go back there?
Do you see me?
Not yet. We do now.
All right, hi. Okay, so I'd like to have the picture centered on the specimen here. This is a demonstration of dorsal root ganglion stimulation. So if we could have the camera centered on the specimen. Okay, well, this will be fine. So what you see is I'm laying my needle on the skin. I have it, this is, the first step to the procedure is trajectory planning. I have the tip of the needle on the skin with a marking that is just beneath the T12 pedicle. The second marking here is my location where I hope to enter into the epidural space and the intervertebral foramen. And then this will be where I plan to puncture the skin. So if you go back to the x-ray, this is what you see here. Shot, please. Okay. Shot, please. Shot, please. Picture. So it really is quite important that you come right down into the middle of the intervertebral foramen for this procedure. If you are not entering into the epidural space right in that midpoint, then the curvature of the dorsal epidural space is going to make it difficult for you to drive your cannula and the lead within it to the direction of your interest.
And for those of you who use loss of resistance, water-filled syringe is very time-honored tradition. You can just use air. Do not use contrast. It's too sticky. So it'll dry out and become very difficult for you to pass any type of catheter or wire
Picture.
through the needle.
So I have gone too far past the midline location, so I'm withdrawing. Picture.
Good. So as long as you're overlying the lamina, you can go down, use the lamina as a depth mark, angle superior and dorsal.
Shot, please. Shot, please. So could I please have the C-arm tilted 45 degrees your direction? So for secondary views, to inform me on my depth and how near I am to entry into the epidural space, I'm going to use a contralateral oblique. And you probably need to lower oh, that'll work fine. So I'm nearly there, as everyone can see.
Very close. Contralateral oblique or laterals can be used.
There I have a loss of resistance. Picture, please. Okay, and back to AP. So this is my introducer. Picture. This is my needle with a rigid introducer catheter that has a curvature on the end. You can see the lead protruding from the tip here of the catheter, just the little nub coming out the end of it. If you look at this midpoint of my device assembly, what you'll see is the lead protruding from the back. If I curve this around, you can see there is a stylet within the lead. And then this hub here is able to tighten against the lead so that when I push forward, my introducer sheath and my lead will move together. The next step is to put some saline in through the side port. And the reason for that is because then it will lubricate the entirety of the sheath so that there's just a little less chance of the lead grabbing as I try to advance it. Picture, please. Okay. So could I have you oblique 5 degrees your direction, please? Just to get a true
Very
AP.
nice angle that she.
And then on my catheter, there are 2 markings. The proximal marking is an indicator, you can see it at the hub of the needle, that my introducer sheath is about to exit through the end of the needle. If you go back to the fluoroscopic screen, thank you. And now I'm gonna picture. All right, so this is the live portion of the procedure, live fluoroscopy. So as I advance my introducer under live fluoroscopy, I am trying to take advantage of that curvature to cause it to exit. Picture out the foramen. I am shooting picture for the inferior aspect of that pedicle. Picture. Okay. Stop. Okay, so I can see that now it is beginning to extend. Picture out that beneath the pedicle. And what you can see under live is, do you see how I'm jiggling this? What I'm feeling is tension. Picture. I'm feeling a soft, firm endpoint, which is caused by one of those many intraforaminal ligaments that I showed to you a moment ago. Picture. So I'm withdrawing it a little bit and just trying to take a slightly alternate route. Okay. So stop, please. It's really trial and error. It's just gentle tapping pressure. Picture.
You can see
Gentle tapping pressure if you do encounter one of those transforaminal ligaments, and you usually will, just rotating the assembly so that you can take advantage of the curvature of the rigid introducer sheath. So at this point, what you're going to see me do is unscrew the hub, which has secured against the catheter. against the introducer sheath. And now if you go back to the fluoroscopic view, please. While holding the lead in place, I'm going to withdraw the introducer sheath. Live. So I want to stop there, actually stop here. Picture. So picture. Okay, now it's more clear. So on my image, you can see the 4 contacts, which are all exactly the same in size. And then you see a small little radio opaque marker that is on the end of the introducer sheath. So you know where the end of your introducer sheath is as you are performing the procedure. I'm going to bring the introducer sheath, leaving the lead where it is, all the way back to the needle. Halfway there. Okay. And now I'm going to a little bit further, I think. There we are. Now I'm going to lock down the hub after I remove some of the stylet to take out the rigidity in the lead so that when I advance it, it is more pliable to a soft bend. And I'm going to lock down now the hub against the introducer sheath, and I'm going to rotate my whole construct. The needle and the bevel is now turned to the opposite direction, as well as my introducer sheath. And I'm going to start to advance live. And hopefully what I'll see is, stop please. So what I'm going to do now is advance. So what I'm looking at here is the contacts that, in my opinion, are just a little bit too far out the neural foramen. So I'm going to withdraw them, but I'm getting some direction from my very handy device representative that his suggestion is instead to advance the lead before I withdraw. Live. So what I'm observing is that it's having a tendency to flip. To stop, please. What I want to do is try to advance the lead itself. So I'm unscrewing. Actually, I can leave the hub screwed down, but advance the lead live. So what I'm trying to do at this moment is create a superior loop. Stop. And what's happening is that loop is flipping. In an ideal situation, it would be a hump, not like a coil like you're seeing now. So I'm going to withdraw my lead live. Okay. And I think what I'm going to do is withdraw everything. Picture. Picture. So I withdrew, as you can see, both my catheter and also my lead, so that the first picture contact is right underneath the pedicle. Now I'm going to advance the catheter with the lead, and it still wants to just kind of go out.
There it is.
Stop. All right, so troubleshooting the situation. Picture. What I think I'll do is just turn my catheter toward the same side, which is certainly not producing the effect I want. Stop, please. All right, and then the next thing I could do would be to advance the lead alone. Live. Stop, please. Okay, so I do have a small superior loop, which would be sufficient for the purposes of a trial. I'd love to see it a little bit bigger, but truly this is sufficient for the purposes of a trial. Now, what I'd like to do is create a little bit of a loop that just reinforces the position of this lead within the neural foramen. So what I'll be doing is turning my whole assembly inferiorly. And live, please. Picture. Stop. And back up toward the patient's opposite shoulder. Live. Stop. So you can see what it's taking some troubleshooting for me to create the strain release loops in the posterior epidural space. And this is part of the procedure. This is really characteristic. Everyone is a little different. Functionally, what we're trying to deliver is a lead that extends out the neural foramen with the most proximal two contacts being beneath the pedicle. This allows a lot of territory for your programming representative to stimulate that dorsal root. And then you want to create, ideally, a strain release loop that extends slightly cephalad, as well as one that is either at the level of the neural foramen or inferior. Could I please see a lateral image? So on our lateral view, what we'll be able to see is that this lead is situated, no problem, in the dorsal one half of the neural foramen, which it is. So this would be a setting for the DRG trial lead that I would be really pleased with and have confidence that my representative is going to have ability to stimulate this L1 nerve root.
Contacts look like little circles sometimes here, directed toward you. Any questions? Very nice, Dr. Lee. Questions, comments? Yes, sir.
I'm going to sign off since I can't hear you very well. I'll come into the room.
Okay.
I'm just wondering structurally, what is the loop surrounding?
The loop is just, yes. The question is, what is the loop surrounding? What structure? It's not. It's in the epidural space. Yeah, so it's just strain relief loops that are designed to keep it in place. And what's keeping the DRG with the electrodes in place, it's the surrounding intraforaminal ligaments. So that has no problem staying in place once you get through next to the adjacent to the DRG. Just so it doesn't pull out, you create S-shaped strain relief loops, and they just set in the epidural space. All right, guys.